see here, this is you see here on the left side, the mechanical nerve arises the thorax and it arches the arch of the aorta and makes a vertical turn, a vertical course and underneath to the left of the thyroid, very close to the trachea. So on the left side, the surgeons can find recurrent nerve very close to the trachea. But in case of right side, the course is not the same. The difference is here. On the right side, the nerve arises on the upper part of the not thorax, but upper part of the thorax, and it arches the right artery. And as you know, the subclavian artery is the lateral of the leg. So the nerve has to take an oblique course to enter into the thyroid. So the surgeon should know this anatomy and this on the right side have a 45-degree angle with the trachea. So in the left side, nerve is found very close to the trachea, in the trachea is usually broke, but on the right side it is never found there. So it is found a bit lateral to the trachea. So this point should be kept in your mind during surgery. And you see here the position. Actually, the identification now, you need some landmark. The important landmark is the inferior thyroid artery. So, surgeon should know the relation of the nerve to the artery. Here is the artery and this is the nerve. So, most of the time, the nerve is underneath the artery. That is the dorsal to the artery. But today you see in the early morning, I got the nerve in the anterior. So nerve is placed anterior to the artery, and sometimes nerve is found in between the arterial branches. So these three relations should keep in your mind during surgery. And here you see on the right side, sometimes the surgeon, the distance is very few. Sometimes surgeons fail to identify the nerve. But you know the percentage is very few, less than 1%. That time the nerve is not non-recurrent. That means the nerve arises in the from the vagus in the upper part of the neck, not in the thorax. So that's time if you find here the nerve, you will not get the nerve. So you have to encounter this situation. So you should keep in your mind that on the right side, nerve may be non-recurrent. For the identification and preservation, the surgeon should use some landmarks, the triangles. So these are the important triangles, the Beers or Riddle's triangle, Lawrence triangle, and so on. You see here, this is the trachea. This is the trachea, and this is your common carotid, and it is your inferior artery. So during operation, surgeon initially easily he or he can identify the common carotid and trachea, right? So he has to need to identify the inferior artery, and for the inferior artery, he has to know the anatomy. Inferior artery is a branch of thyrocervical trunk that arises in the lower part of the neck, and it crosses deep to the common carotid, and it enters, take a horizontal course to enter into the thyroid gland. So during dissection, we should find the inferior artery underneath the common carotid. So if you under the carotid, common carotid and inferior artery, so we use the trachea, and this is a triangle. Here the inferior make a base. So we during operation we use this triangle, the Lawrence triangle. It bounded by medially trachea, laterally common carotid, and base is formed by the inferior carotid. But somebody is used another triangle, not the Lawrence triangle. If you use the Lawrence triangle, then nerve will be your content. There is a few fibrofatty tissue, and you dissect, then you will get the nerve. But if you want to get the nerve, you need to do the meticulous surgery, bloodless surgery. It is the prime need. And sometimes the surgeon uses first the common carotid and the inferior artery, and he tries to identify the nerve just above or below or in between the inferior artery. Then the nerve is on his medial boundary, so it is the bare spine. So if uses the esophagus on the medial boundary, then it becomes the Simon's triangle. So during operation, this triangle should be kept in your mind. So it is an operative patient. Here you see it is a Beer's triangle, right? This is our inferior artery and recurrent nerve and common carotid. So this triangle is a Beer's triangle. And triangle of Monson. During thyroid surgery, surgeon faced to some problem in hemostasis or controlling the bleeding. So this is the triangle known as the triangle of Monson. What is this triangle? You see here. This triangle is bounded in the midline. This is the midline over the trachea, and laterally it is bounded by the recurrent nerve, and inferiorly it is bounded by the hyalothymic ligament. So this area is a triangle of concern. Why it is a concern for the surgeons? As you know here, the inferior thyroid artery gives some branches here. So during surgery, the surgeon should take measure to handling the minor blood vessels, and he should uses the cautery cautiously. So this triangle is known as the triangle of concern. Otherwise, you may injure the recurrent nerve as well as the branches to the parathyroid artery. So you should be more careful here. And recurrent nerve, it is sometimes used in some surgeon when there is if the tumor is so big, or in malignant case, or rectal water. So if you do not enter into this point, right, this triangle, either a Lorentz triangle or a Beer's triangle, so the surgeon is in difficult position. So he can use another triangle that is called the recurrent laryngeal nerve triangle. What is that? If I place the thyroid here, the lower pool will be the base. Lower pool will be the base, and trachea will be the medial boundary, and retracted sternocleidomastoid muscle, or if you go through the midline, that time the sternum muscle will be the lateral boundary. So this triangular area is known as the triangle of the recurrent triangle, and it is lower in the neck, and here only there are some fibrofatty tissues there. So your minimum dissection, you can find out the nerve in case of used thyroid. So now the preservation technique. First we need to identify, already I told, then nerve may be posterior or maybe anterior or in between the artery, and find out the nerve. Already Professor Motin sir told early in the morning, we should start searching the nerve from below, not from above. Because if you start searching the nerve above the common carotid, the inferior artery, you may miss one branches. You know, the most of the time recurrent nerve is divided below the level of inferior artery. So nerve should be identified below the inferior artery, not above. After getting the nerve, we just trace the nerve from inferior to superior by ligating the inferior artery to its branches in the towards the gland, with the preservation of branches to the parathyroid. And near the Beer's ligament, you know, at the upper port, the nerve should be separated from the thyroid by sharp dissection. We should avoid the use cautery, as the nerve is very close to the thyroid gland. So we should be careful and we should dissect, sharp dissection. For juniors, during the operation, we may injure the nerve. There are many mechanisms of nerve injury, and the students are asked in the exam. These are what are those mechanisms, right? It may be you can stretch the nerve, or you may cut the nerve, you may track the nerve, traction, more traction during parotid surgery. Respected Sir Mujumdar sir told Ajad that traction is so powerful traction. So powerful traction is very important for the not to injure the nerve. So you may injure the nerve by traction. And sometimes the people is handling the bleeding. So sometimes somebody ligate it, the nerve may be interrupt the ligation. And sometimes we are very enthusiastic to control the bleeding by using the cautery. So nerve may be injured by thermal or electrical injury. So these are the mechanism. Some condition that that predispose the nerve for higher risk of injury. That is the if you did not identify or you are not able to identify the nerve should be falling a risk. So without identification of the nerve, you cannot do thyroid surgery. If you do it, you may injure the nerve. So identification is the key to preserve the nerve. So lack of identification may injure the nerve. And sometimes you see the malignant disease. So if you do the malignant thyroid surgery, then that time you need to be careful. And if you dissect the neck node in the level 6, that time you also keep in your mind that the nerve may be injured. So the incidence of the injury is written in the book. You know there is a 0 to 6%, and most of them are temporary. And in a study, they show that if the surgeon is only the localized the nerve, he did not identify the whole nerve, only he recognize that means localize the nerve, then there is a chance of injury is 0.9%. And he did partial dissection, the nerve incision goes down, it is 0.3. And if a surgeon dissect the nerve in whole length, that the injury chance become only 1%. So it is a big important issue. So you should dissect the nerve in full length. Now come to the external branch of the supralaryngeal nerve. So this is the supralaryngeal nerve usually arises from the vagus, and you see here at the level of middle of the thyroid membrane, the nerve divides into two. One is the internal, another is the external. Internal one goes to the larynx along with the supralaryngeal vessels, and external branch see here, it goes down, take a course with the suprothyroid vessel and keeping from lateral to medial. So the relation in the upper part of the thyroid, the vein is more lateral than artery and the nerve. So for the identification of sarnia, the Brazilian thyroid surgeon, they made a classification. Already I told in the early in the morning. So they told the type 1, type 2A and 2B. The type 1 is nerve crosses the 1 centimeter above the upper pole, and type 2A is within the 1 centimeter, and 2B is through the below the gland. So type 2 is called the high risk nerve. So you see here, this is the type 1, this is the type 2 and type 2B. So these nerves that passes above the 1 centimeter, type A to 1, it is safe nerve, and the chance of injury is less. But the type 2B is underneath the upper pole, so it carries more risk. With all, if you all the attempt, you may injure the nerve. Jaws triangle already I told early in the morning. This is the jaws triangle. The base is formed by the step muscle, and middle boundary is midline, and laterally there is a superior vascular pedicle, and nerve crosses from lateral to medial. So nerve is found in this floor. That is, the floor is formed by the cricothyroid muscle, and the floor, cricothyroid muscle, and the upper part of the thyroid. In between that there is a avascular space, this space is known as space of ribs. So somebody take the advantage this avascular space and easily find out the nerve. So what is the technique of preservation of the external branch? Number one is visualization. You should see the nerve. How can you see? Either you can use the lobe or you can microscope. But lobe is not the alternative of microscope. You should microscope if you try to see the nerve. And number two is that if you do not have microscope or the lobe, how can you preserve the nerve? Then you can sclerotonize or you just dissect the upper port and you individually ligate the upper port vessel individually and automatically your nerve will set. So if you do not have this scope to use microscope or lobe, you can use that technique as well. And you should avoid using the cautery in the rib space or in the cricothyroid muscle. If you use there cautery, you may injure the nerve without knowing you are damaging it. So this is microscopic picture already early in the morning you saw. This is the external branch of the external branch, and this is our superthyroid, and this is the superthyroid vein. So now come to the parathyroid. You know that already I told early in the morning parathyroid get blood supply. Actually single blood supply is the end artery. End artery means if you have the ligate or injured the one or blood vessel or if blood vascular supply, he becomes devascularized. So you should keep in mind you never you cannot ligate or injure the